how to treat arrhythmias is a very important part of your job in the sense that you've got to be able to identify it and then correctly manage it. By far, the most important part about treating an arrhythmia is identifying the cause. If you can identify what the problem is, that's really much more important than starting pulling out the medications and just throwing all the medications at this. So really identifying the initiation, what's causing the initial arrhythmia is the most critical aspect of it. A lot of people forget this and they go right away to the drugs without thinking about what's taking place. The treatments that you have available for cardiac dysrhythmias are basically only 4 things. You have antidysrhythmic drugs, okay, which you should be fairly good at managing that, and at least knowing that which drug to use in which situation. Cardioversion, okay, which is for arrhythmias that have still some form of normal activity, and then defibrillation, which is things like unstable V-tach, V-fib. Those are defibrillation reasons. And then, of course, pacing. The antidysrhythmics work by 1 of 3 mechanisms. They work by suppressing automaticity in the pacemaker cells, by decreasing the slope of phase 4 depolarization, okay? And by decreasing that phase 4, you basically slow down the heart, okay? If you alter that phase 4 increases. If you increase the slope, you increase rate. If you decrease the phase 4, it takes longer to hit threshold, so heart rate begins to decrease. Now, one of the things that happens when you develop different forms of dysrhythmias from different kinds of cells is some cells are sick in the sense that they are more rapid in their phase 4 slope than normal. So instead of being the SA node that actually causes this initiation, you may have individually sick cells that are actually getting to threshold much more rapidly, and that causes things like atrial fibrillation and atrial flutter. Okay? Atrial fibrillation, if you think about it, is your fingers are the points of these sick cells. Atrial fibrillation means that they're pumping, they're actually causing an erratic electrical activity inside the atrium, okay? Which causes some of these will conduct through the AV node and cause tachydysrhythmias to take place. In atrial flutter, you have a different disease process, which again, think of the points in your fingers as being the initiating events, but what you're seeing is instead of being multiple, it's coming in sequence, one followed by the next one, followed by the next one, but it's occurring more rapidly than it should be. Okay? The atrial flutter tends to have a sawtooth pattern versus atrial fibrillation because it's coming from many different locations at the same time, gives you this distinct sort of very flat up and down pattern. It basically looks like fibrillation. The other reasons that you get dysrhythmias is from a prolonged effective refractory period to eliminate reentry circuits. Okay, you can also the antidysrhythmic drugs can help by facilitating impulse conduction along normal conduction pathways in order to prevent a conduction over a reentrant pathway. So reentrant pathways are also a big problem causing arrhythmias. Now, this table you should know like the back of your hand. Okay? Sorry, guess what? You have to know this. When you get to clinical, it's not going away. Okay? Now, what I've done for you is in this basically breaks it down into different classes. Okay? I wish there was a better way of doing this, but what I've found the way it works better is to imagine understanding the receptors. Okay? And the DNAP level, I sort of explained that to in more detail with them. I think it's still a little bit above your level at this point, but I want you to understand first that the actual antidysrhythmics select the action on a specific receptor on the cardiac muscle or the cardiac pacemaker. Okay? Remember that cardiac pacemakers are different than the actual cardiac muscle. Okay? In the cardiac pacemakers, the actual initiating event is not fast sodium channels. Remember, fast sodium channels are the cardiac muscle. Okay, that's what causes the fast upstroke. What is due to what causes the uptake? What happens to when it hits threshold? What opens? Calcium. Very good. Calcium. Okay, it's a slow calcium channel opening. Okay, that's why calcium channel blockers work more selectively on pacer cells than they do on cardiac muscle cells. Okay. Now, the cardiac muscle cells also have calcium channels, but their calcium channels are there to keep the plateau phase for maximal muscle contraction. So a different mechanism completely than pacemaker cells. The other important portion is the repolarization effect of potassium, which has to do with the ability for potassium to exit the cell and cause the cell to repolarize and reach back. So these drugs that we use are effectively going to bind to specific receptors and cause their action. Okay? In class 1A drugs, okay, are fast channel blockers. Okay? These actually are used mostly for ventricular arrhythmias because these are fast channel blockers. Okay? They're not slow. They're the fast sodium channel blockers. They actually block the sodium channels, and because we're looking at fast, what does that mean? There is no fast sodium channel blockers there's no fast channels inside the pacemaker cells. So these drugs would not be effective for, let's say, atrial arrhythmias or pacemaker kind of problems. Instead, they're more for ventricular arrhythmias. So type 1As, simply because they're fast sodium channel blockers, they like quinidine, procainamide, and diacylpyramide are all ventricular antiarrhythmics. Okay? They suppress the fast sodium channels from opening, and it prevents the threshold to be reached, so you tend to eliminate the VTACs and the VFibs as much. Okay? Procainamide has also been used in Wolff-Parkinson-White because it also suppresses more effectively the actual refractory pathway, the accessory pathway, than the normal pathway. Okay? Because the normal pathway is made by pacemaker cells, so you expect that it wouldn't be affected as much, versus the accessory pathway a lot of times has other cells that are more like ventricular cells, and as a consequence, these block this area a little bit more significantly. Now, type 1B agents are all, again, also are fast sodium channel blockers, okay? But the nice thing about them is also they work for ventricular arrhythmias. Okay? They're not really set up, again, for pacer cells. So lidocaine, phenytoin, mexiletine are all, again, type of sodium channel blocker, and as a consequence are used for, again, ventricular arrhythmias, not really atrial arrhythmias as much. Okay? Sometimes it can be effective for for the atrial fibrillation when it's outside of course the SA node, because in that situation that's muscle. So again, it affects muscle, not affects pacemaker or conduction wiring. Okay? The type 1C agents are sodium channels. Okay? But what makes them different is that they have slow association-dissociation effects. So in other words, they're used for long-term care. Okay? Flecainide, encainide, propafenone, and morizidine are all used for, again, this atrial fibrillation, and also used for ventricular arrhythmias. Okay? The downside of using 1C agents is that everybody dies with these drugs. Okay? They have no arrhythmias, but they actually look great. Okay? So you'd expect that these people would do well. But what the studies have shown actually that their mortality rate goes up. Because if they do have an arrhythmia through these drugs, guess what? They don't have any ectopy to restart the heart. So the heart won't restart. So what we've actually done because of these studies is we've gone away from using these 1C agents, and now we're using almost exclusively pacemakers. Okay? Yes, sir. Okay. Because, okay, there's different portions of the heart, okay, that's in the atrium. The pacemaker cells in the heart are the SA node, AV node, and the His-Purkinje fibers. Those are all conduction and pacemaker potential cells. And there's also the wires that connect between the SA node to the AV node, are also like conduction wiring that's like the pacemaker cell. Okay? Atrial fibrillation actually occurs in some people, not in those wires. but actually in the portion of the atrium that does the contraction work. Okay? And that's what's atrial fibrillation. Atrial flutter tends to be still a disease process inside the conduction wiring. That's why you see that sawtooth pattern, and it sort of follows still some degree of conduction going to the AV node that's coherent, versus the one that's atrial fibrillation. It could be anywhere in the atrium. And a lot of it, most of the atrium is still muscle. It's still cardiac muscle. So that's why you get these drugs will work for that in atrial fib. You see it doesn't work for atrial flutter. Okay, atrial flutter is more the conduction wiring, so these kind of agents wouldn't work for that. It works more atrial fib. If it's atrial flutter, you use the conduction system, which I'll show you that in a minute. Okay, so you would ask to use slow calcium channel blockers. Okay, would decrease the effects on those. The other thing you can use is AV blockers for atrial fib, just to prevent the rapid conduction through the AV node. Okay, but you're not still treating the conduction problem origination point, which is up in the muscle of the atrium, which is what the other agents can do. You can chemically cardiovert them with those other agents. Okay, lidocaine is very frequently used in the operating room because it's very fast acting. It's a type 1B agent. It's got a fast association with fast dissociation. So if you get into trouble, you can get out of it pretty quick. That's why we like it. Okay. The type 2 agents are actually beta blockers. They bind to beta 1 receptor sites, and as a consequence, decrease the slope of phase 4 and cause the slowing of the heart rate down. Things are more selective than others. Esmol is a pretty great agent. Metoprolol, beta 1 agent. Atenolol is also a beta 1 agent. They decrease the incidence of myocardial infarction and also decrease some degrees of tachycardias. And you have the type 3s. The type 3s are the potassium channel blockers. And the potassium channel blockers, what they do is they help with the refractory phase. And I have this whole picture on how it affects the, I don't think I have it on this slide presentation though, to try to explain to you how these antiarrhythmics work. Okay? Most of these drugs prolong the refractory period, and as a consequence slow down the arrhythmia that you may develop. What you get with, what you get with tachydysrhythmia sometimes in the ventricle is you get such rapid repolarization taking place that's able to reach threshold more rapidly. So by using these drugs, you're actually making that distance get wider. Okay, so it takes longer for phase 4 pacer cells, or in this case, for cardiac muscle cells, it takes them longer to get back to threshold, and as a consequence, slows the heart rate down. And it eliminates some of the ventricular arrhythmias that you may see. So amiodarone specifically is the actual potassium channel blocker. Sotalol is also a combined potassium and beta blocker. So not only does it heart rate decrease by affecting the SA node and AV node, but it also affects the ventricular irritability and represses it. Okay? It's also very useful in a lot of these agents to be used in Wolff, Parkinson, White, because it's affecting the reentrant pathway much more so than the AV node. The next one is the type 4s, which is the slow calcium channel blockers. Okay, these affect contractility at times because of some crossover effect, but it's really specifically made for more atrial arrhythmias. Verapamil and diltiazem both are SA node as well as AV blockers. Specifically, they're very good at AV blocking somebody. So they're very good for atrial flutter and atrial fibrillation, where you want to prevent the atrial flutter or atrial fibrillation from accelerating the heart rate too much. Yes? No, they're preventing the potassium from leaking out too fast. Okay, so it slows them down. So you don't repolarize as fast. And because you don't repolarize as fast, you don't come down a threshold quickly. So it takes you a longer time to get there. Okay, I wish I had the pictures of it. I've got the whole thing broken down so you can actually visually see it. I might have it on one of these slides. I think I added them to here. But let me just wait. Let me see if I can get to it. Well, for muscle cells, you're extending the actual duration of the actual phase 3. So instead of phase 3 being sharply coming down, it slopes it out. And as it slides it out, it takes more time to repolarize that cell. So while it's doing that, it's still not able to fire again. Okay? It's only when the sodium channel is closed completely that you can actually fire. If your sodium channels are still closed at that point, and you're going into the now what's called the not absolute, but the effective refractory period, you can overcome it. Okay? So in some situations you can overcome it and bypass some of these effects. But these drugs basically poison the potassium release, and it basically suppresses the refractory, suppresses the repolarization that take place in the cell. I have to sort of show you the drawing. See if I can pull it out a little later on. I don't have it. The last one is the type 4s, which are adenosine and digoxin. They work by an unknown mechanism. We think that they affect by nodal inhibition. Okay? Adenosine is a byproduct of normal cell metabolism. We do know that if the heart works too hard, it starts releasing lots of adenosine. It's a way of starting to slow down the heart. So normally adenosine will slow down your heart when you're about to explode your heart by working too hard. So it begins to release that to slow it down. It's a negative feedback mechanism. When you give adenosine, we're giving a maximal dose of 6 milligrams initially, and you give it through a big IV, or you put it close to the heart as possible. I always warn patients before you give adenosine that they're not going to be happy, because they won't. Okay, they feel nauseous, they feel they're going to die, and their heart does stop. And the first time you give it, you go, oh my goodness. Okay, I don't know how many people have given adenosine. Okay, how many people freaked out the first time they gave it? You guys got irons, man. That's good. Well, not me. I was very scared when I saw no heart rate for about 15 seconds. I was rather impressed by that. And then the atrial fib, got out. But most of the time they tell you that this is effective to reverse that effect. It's been only found that about 25% of atrial fib actually reverts out of it into sinus rhythm. So it's not that. It's more for diagnostic purposes to know what you got underneath. Procainamide is a type 1A agent. It slows conduction. It's your fast sodium channel blocker. Okay, indications for ventricular tachycardia and with a pulse. Atrial flutter is really not something that most of us use procainamide. We will use it for fibrillation, okay, especially in WPW syndrome. SVT resistant to adenosine and vagal maneuvers may also be effective for this. 50 milligrams per minute IV until the arrhythmia is suppressed, or significant hypotension as occurs, the QRS complex is prolonged by 50%. Okay? Caution, it should be used with patients with pre-existing QT prolongation, and to maintain therapeutic levels, you need to maintain an infusion rate going around 1 to 4 milligrams per minute. Doses should be reduced in patients with renal failure because you do get accumulation of this drug. Okay, here's what I was trying to show you before. Okay, this is what actually happens to the muscle cells itself. These are different than cardiac cells. This is the actual muscle cells. Okay, in a class 1 agent, okay, what you see is suppression of the fast channels. Okay, in this case, you'll see here the effect is slowing down. And as a consequence, you get this increase in refractory period, and so it slows down the heart rate. Okay. In class 1B, it does the same thing, but what they don't show you in this is that it also shortens it up this way, and it slides the actual depolarization effect, and the person will shortens the action potential. And in flecainide, you don't see that effect. Instead, you see a very significant suppression of the sodium channel as a consequence, and you'll get these arrhythmias to stop and develop. Okay? Lidocaine, which blocks the sodium channel again. These are all one agents. Any type 1 agent is a sodium channel blocker. Okay? Again, it's for the same thing. It's treatment for ventricular ectopy, especially for short bursts of DTAC. Okay? It's alternative treatment for amiodarone and cardiac arrest and ventricular fibrillation. It does not treat atrial arrhythmias, again, because it's not going to affect the slow calcium channel release from the pacemaker cells. The dosing that we give is 1 to 1.5 milligrams per kilo, and then you have to give it every 5 to 10 minutes to make sure that it accumulates out and stays at its therapeutic level. The maximum total dose you should give is around 3 milligrams per kg. Redistribution is why this drug stops working. Okay, you have to sustain therapeutic effects. You've got to give a continuous drip. The downside to this drug is that eventually it does cause central nervous system symptoms such as tinnitus, drowsiness, confusion, and seizures. Okay, there's minimal myocardial depression usually seen, and minimal negative inotropic effects. So it's, in that sense, it's safe. It has extensive first-pass hepatic metabolism. So when you give it orally, it's not well taken. You can give lidocaine IV with it missing that first-pass effect. Drug interactions is it may actually be affected by cimetidine and also increase the plasma concentration of lidocaine. The beta-adrenergic blockers, which are type 2 agents, they ameliorate the effects of circulating catecholamines, and they decrease the actual beta receptor activation. Indications of preserved left ventricular function will require ventricular rate control, such as atrial fibrillation, atrial flutter, and narrow complex tachycardia. Okay, side effects is too much of a good thing, which is severe bradycardia. Esmol has actually caused some people to die in the operating room. The reason being is when you get your Esmol, it's 10 milligrams per cc. Every once in a while you'll see a vial come up from pharmacy, and that vial has a gold band around it. That's not a good one to pick up. Send it back to pharmacy. It's 1,000 milligrams per cc. Okay, that's what's killed people in the past. They break that vial open and give it because they think they're giving 10 milligrams of Esmol, and all of a sudden you've got no heart rate. Okay? Yeah, wow, exactly. Yes, you have a question? They bind to different portions of the sodium channel, but they affect always fast-acting sodium channels, so it only affects cardiac muscle cells, not cardiac pacemaker cells. Okay? But they act differently based on where they bind onto the sodium channel. Okay? I don't like the picture that I have here. Okay? I've got a better one that I've actually produced on my own, which shows a lot more of the effect based on some of the reading I've recently done, and it makes it a little bit more understandable. This is not quite right. There's some deviation here because it's fast sodium channel. What it does is it also affects the refractoriness of the calcium channel here. So class Bs have a little bit of effect on calcium channels, and that's why the plateau shortens up. Okay. Yes? Yeah. Yep. Yep. If you see right here, anything that shortens this up would decrease your contractility. Right. And that's why it tells you that if you give flecainide to somebody who's in congestive heart failure, you're making him worse. Okay. And that's why there's a risk associated with that. Okay. You can see lidocaine doesn't seem to have that much effect. Okay, it shortens it just a little bit, not enough to be significant. So you can give it to somebody who has a contractility that's diminished and not have much of an effect. But flecainide and encainide and all those type 1Cs, they do suppress the heart. Okay. Because most of the time when you're giving procainamide too, I mean, look what you're doing with procainamide. You're shifting the whole thing. Has it really affected the contractility at all? The answer is no. So that's why we give it in code situations. It doesn't really do anything bad. You would never want to give flecainide to somebody in a code situation. It would take too long to work, but also it would be very bad in low cardiac output state. It's not something you'd want to do. Okay? Good question. Now you're starting to understand by looking at things. That's good. Okay? That's the whole point of this stuff. Okay? Beta-adrenergic agents are basically going to be contraindicated in third degree or second degree heart block. Patients that are hypotensive can be made more hypotensive by giving them beta blockers. Patients with severe congestive heart failure, not chronic but severe, or acute onset, meaning it's contraindicated to give them beta blockers. Patients with asthma or severe forms of chronic obstructive disease that have that bronchospastic component can actually be made worse by beta blockers. And they're not useful in the treatment of atrial fibrillation or atrial flutter associated with WPW. Okay? So it's not really a good idea to give these people WPW. May actually contribute to clinical deterioration in this kind of situation. Amiodarone is a type 3 agent. Okay. Now, I have seen, let me just go back on this. I have seen that people have given Esmol for WPW, and it seems to have worked for some situations. The only downside to that is sometimes the reentrant pathway can accelerate the heart. Not as much as you might think, but it's not really treating the problem. Okay. WPW syndrome is an accessory pathway, and you're not suppressing it by giving that person beta blockers. So all you're doing is you're decreasing the rate of initiation, but you're not treating the suppression of that refractory pathway, okay, accessory pathway. The amiodarone, of course, is a very potent agent. It's a potassium channel blocker. Okay, it blocks not only sodium, but also blocks a little degree of calcium, but it's really considered more of a potassium channel blocker. It prolongs the refractory period of the myocardial cells. It's indicated for VFib and VTAC. Okay, it's basically a very good agent for reversing some of these effects. It's metabolized by the liver and slows the metabolism, increases blood levels, and if other drugs are metabolized by the liver, such as Coumadin, quinine, procainamide, all those other drugs that are being broken down by the liver will affect the amiodarone and will cause amiodarone excesses. Amiodarone is also considered the blue Smurf drug. Okay? When you give it to prolonged periods of time to somebody, it will actually begin to accumulate in the skin and will crystallize, and the person will turn blue. Okay? Sotalol is something new that's coming down the market. It's actually not that new, but it's becoming more to the United States. It is also a type 3 agent. Okay? It does affect not only beta sites, but also begins to also affect the potassium channels. So it prolongs the duration of action potentials and increases the refractoriness of cardiac cells, and it's beta blocking. It's very well indicated for ventricular tachycardia, atrial fib, and atrial flutter in patients with WPW syndrome. Also very effectively treated with sotalol, but it's still not considered a first-line antidysrhythmic drug. This is more something that we use in chronic stages. Calcium channel blockers, of course, are the type 4s. Okay? They inhibit basically calcium influx into the cell. So it does affect myocardial cells as well as affecting the cardiac contractility cells. Okay? It does inhibit to a certain degree the contractile process of all myocardial muscle. It does dilate coronary and systemic arteries. It does slow down the conduction by affecting the AV node and increases the refractoriness of the AV node to reentrant arrhythmias. Okay? The downside of this drugs is that if you give it to somebody with WPW, you actually accentuate the accessory pathway, and you can actually get a severe tachydysrhythmia, and including VFib and VTAC. So the verapamil is not really a good idea. Diltiazem may also not be a good idea in WPW, as it doesn't seem to work as well. Treatment is a narrow complex tachycardia who have failed. You have to know what a difference between a narrow versus wide. Wide complex tachycardia are the ones that are seen with WPW, but a narrow complex tachycardia can be treated with vagal maneuvers or adenosine, the ventricular rate control due to atrial flutter or atrial fibrillation. Okay. Contraindicated for accessory bypass tracts such as WPW. Verapamil actually causes acceleration and cause increased ventricular rate, including ventricular fibrillation and ventricular tach. Left ventricular dysfunction and heart failure may also develop, and it's not effective in treating tachydysrhythmia originally below the AV node, because this is not what? This is really not for the cardiac muscle. This is really for the pacemaker cells, which are both the SA node and AV node. If you give it in high enough doses, the PR interval will get very wide and eventually completely heart block you out. So be careful of that. Beta blockers, second, plus calcium channel blockers lead to second or third degree heart block. So you gotta be careful with those. Adenosine is an alpha agonist drug. It's a normal byproduct of cellular metabolism for the cardiac cells, indicated for hemodynamically stable AV node reentrant tachycardia. 60% say will terminate in dose of 6 milligrams. That's really been found to be around 25%. 32% will respond to a 12 milligram dose, and that's fairly true. So if the first time it doesn't work, give it again. Rapidly terminated by active transport into red blood cells, and adenosine has approximately half-life of 10 seconds. It should be rapidly injected and flushed through with an IV tubing bolus. Adenosine usually causes facial flushing, dyspnea, severe nausea, lightheadedness, headache, sweating, palpitation, and blurred vision. Indications are dipyramidal pretreatment increases the potency of adenosine, so be careful of that. Carbamazepine potentiates the action of adenosine, and caffeine and theophylline also can actually antagonize the action. Heart transplant patients may require only 1/3 or 1/5 of the usual dose, and it's contraindicated in patients with 6 sinus syndrome or third-degree heart block. DIG is an X agent, which is a class 4 agent, which is a cardiac glycoside. We think the way it works is basically inhibiting the myocardial cell sodium-potassium ATP membrane pump. It actually increases the inotropic effects by increasing intracellular calcium and increases the actual phase 4 depolarization, which shortens the action potential. It decreases the conduction velocity through the AV node and prolongs the actual AV refractory period. Okay, so DIG is a great agent if you're trying to prevent the heart from going fast by blocking the AV node. It's indicated in some patients with congestive heart failure, as it actually increases contractility, and it's also indicated for prevention from SVT due to atrial fibrillation. So giving this, you can actually prevent the rapid tachycardia you get from atrial fibrillation. Most people will agree with me when they've been working in clinical for a number of years. The books disagree, so I don't know who's right, to tell you the truth. The books say that the atrial fibrillation is not reversed by digoxin. My personal opinion is if you see somebody who's on DIG, I've seen them reverse out of it once the heart rate slows down. So is it because the DIG is doing it, or is it because the DIG is slowing down the heart rate enough that then it reverts back to sinus rhythm? It's unclear. But I can tell you the DIG is very effective at times when you get yourself into trouble. It, according to the books, does not convert atrial fib to sinus rhythm, although I've seen that happen enough times. The onset of therapeutic effects is 5 to 30 minutes IV. So when you give it slowly, 0.125 at a time. Okay. Peak effect is 2 to 6 hours. It has, unfortunately, a narrow toxic to therapeutic index, therapeutic ratio, especially in the presence of hypokalemia. The high serum DIG levels can cause a variety of symptoms, but the DIG levels don't always tell you the story, so don't even waste your time doing it. A DIG-specific antibody is available for patients that are toxic, but most pharmacists are not going to want to give it to you because it's like $10,000 a dose. So it's not something that's cheap. Okay, it's an antibody that is specific for DIG, and it's very expensive to make. Magnesium is another anti-arrhythmics. It's indicated for ventricular fibrillation and pulses V-tach. Its dosing is to size the point, usually hypomagnesemia, and you can give 1 to 2 grams over 5 minutes. Then you have a discussion on chronotropic and inotropic agents. Epinephrine is a alpha and beta affecting drug. Vasopressin, which is another name for antidiuretic hormone, is when given in very high doses as a very potent alpha agent. Okay? But you have to have really high doses for it to be effective. Vasopressin is now apparently taken over pretty much what epinephrine does because it's been found to be possibly more effective in code situations. That's still to be presented as being the right choice. We went from normal epi to high dose epi. That was in vogue for a while. Then we're now back to very potent alpha agent, which is vasopressin. Will that be really showing the survival increases? It's still for debate. And we'll have to wait and see what the final studies come out. Atropine, of course, is your anticholinergic drugs, okay, which block the ability for acetylcholine to bind from the parasympathetics, which then the sympathetics will take over and accelerate heart rate. Isoprosternol, which is a selective beta agent, beta agonist, which increases heart rate. The downside to it is also a partial beta 2, and may also cause some vasodilation peripherally as a consequence. Isoprosternol is never indicated in codes conditions because it causes significant drops in blood pressure, and that's the last thing you need in a patient's in coding condition. Dopamine is a nice agent because it has a combination of three things. It has the dopaminergic qualities at low doses of 1 to 5. At 5 to 10, it's got the the beta, and the we'll go above 10 mics per kilo per minute. You're up in the alpha range. Epinephrine is a vasopressor with alpha and beta indications beneficial for CPR to increase coronary and cerebral perfusion. There are a few objective studies to show definitive proof that epinephrine improves survival, believe it or not. Suggested doses are 1 milligram every 3 to 5 minutes. Occasionally, larger doses may be needed to treat cardiac arrest due to beta blockers or calcium channel overdose. Route of administration is intravenous or intratracheal. Okay? What are the different drugs that you can give in the trachea? There's 5. Naval, Narcan, atropine, V for Valium, okay. E for Epi, L for lidocaine. Naval, that's how you remember it. Okay? Same thing for naval down here for your regional. You guys have learned that already, right? Naval for the nerve, artery, vein, empty, lymphatics. And the L is always in the middle. Doesn't matter which side you flip it on. Okay? Vasopressin is a potent peripheral vasoconstrictor. It does not work by alpha or beta-nergic mechanisms. There's some more of an alpha kind of effect. It's a severely potent peripheral vasoconstrictor. They're interchangeably recommended for cardiac arrest. Usually about 40 units IV are given. May replace first or second dose of epinephrine in the treatment of cardiac arrest. The new recommendations are going now towards recommending using vasopressin more so than before. So we'll see how it works out. I haven't been impressed so far. How many people have given vasopressin? Have they seen that much of a difference? I mean, if you're dead, you're dead. That's the way I look at it, you know. Nothing's bringing back Lazarus unless you got to use a higher dose, and you better do a lot of CPR. Atropine are vagolytic agents. Okay, they're also, of course, your anticholinergics. Their actions to increase heart rate, blood pressure, and systemic vascular resistance by basically inhibiting the parasympathetics. They're indicated for bradycardias, anasystole, or pulsus VTAC, or pulsus electrical activity. Dosing is 1 milligram every 3 to 5 minutes, and maximum dose of 3 milligrams. At above 3 milligrams, the atropine actually will go through the blood-brain barrier and cause a tremendous amount of sedation and other kinds of side effects, which is cholinergic crisis to the brain. Isoproterenol is a sympathomimetic. Okay, it's a beta-1 and beta-2 agonist, okay, with no alpha effects at all. And because of that, it actually causes peripheral vasodilation. Okay, not a good idea. It has a 100% mortality rate if you give it to somebody who's coding. So it's not something you want to give. Okay, it's for bradycardia and heart transplant patients most of the time. Dopamine, I just went through that, so I'm going to keep going. Okay. Into electrical activity. Electrical cardioversion is different than defibrillation. Okay, in electrical cardioversion, you're taking electrical discharge. You have 2 electrodes placed in anteriorly and 1 placed posteriorly. The current is then synchronized to the R wave. You see right here, it actually's got syncing to the R wave. Okay. Then when you fire it, basically fires properly. It's delivered during the refractory period of the ventricle, that is during the T wave. The electrical stimulus could, if it's done in the wrong place, it can actually invoke VTAC or VFib. Cardioversion should be done at lower doses, usually at 50 to 100 joules, and then increased. Okay? And defibrillation attempts start with outputs of 150 to 200 joules, so it's very different than cardioversion. Okay? Synchronized cardioversion requires, what are the indications? We do these quite a bit, okay? But it's not a benign process. You can actually kill somebody when you cardiovert them, okay? And one of the things that really scares me is a lot of people in anesthesia don't realize how dangerous it is. One of the things that I'm acutely aware of, because I used to be an ICU doctor, is that all the drugs that you give during an induction for an anesthetic may actually affect the actual performance of the heart. So the last thing you want to do is you want to knock the person down with no blood pressure, and then you give them a suppressant such as lidocaine, which then when you cardiovert them, the heart stops completely like it's supposed to, then it doesn't restart. Not a good idea. So lidocaine should never be given to somebody who you're planning to do a cardioversion on. Okay? And people forget that because they're so used to giving a little bit of lidocaine before they give propofol because it hurts so much when you give propofol by itself. So we tend to give the lidocaine initially. But in this situation, you may actually kill the patient by giving the lidocaine. 100 milligrams goes a long way, so don't give it to these people. Okay? The next thing you do is when you give Diprivan, don't hit them so hard that you lose your blood pressure. Okay? You want to just give it enough that they're sedated. You don't want them to be without breathing. Okay? If you develop apnea and you have to ventilate the patient, what happens to your diastolic pressure when you ventilate a patient? It drops like a rock. Okay? And if the patient's heart stops and you're having to spontaneously, if you have to breathe for them, then you're going to have a hard time getting them back. Again, things that you don't want to do. Okay? Don't make them hypotensive and then have to ventilate them and then wonder why they don't come back when they actually do a cardioversion. Okay? The worst thing to possibly see is somebody that has an ambu bag on a patient. When you put an ambu bag on a patient, can you really effectively pre-oxygenate somebody with an ambu bag? Okay, if you don't believe me, you don't have to. Nothing I say has to be on a rock. Okay, go try it yourself. Put an ambu bag on your face and try to breathe through it. You're going to be really surprised how bad it is. Okay, there's actually a valve, okay, which is a one-way valve that you have to open when you want to get an oxygen. Okay, so that's a lot of workload. That's not something you want to do right before you have to be cardioverted. Okay, so smashing a mask on somebody's face and giving them an ambu bag, you're not going to pre-oxygenate them properly. Okay, the only way they actually pre-oxygenate with an ambu bag is by squeezing the bag and opening the valve for them to help them pre-oxygenate them properly. The better way to pre-oxygenate them is just give them 100% FiO2 mask up front. That's much more effective. Okay. The indications are, of course, SVT, atrial flutter, atrial fib. Okay. There's also digitalis induced through dysrhythmias or refractory to cardioversion could trigger more serious ventricular dysrhythmia, so you've got to be careful of those. Okay. Cardioversion of atrial fibrillation carries a risk of systemic embolization, which is why we tend to do TEEs before these now. In the past, we used to do them without even thinking about it. Now, we're much more careful with it. We do a TE beforehand. If we see a blood clot, then guess what? We're done. That person gets 6 weeks of anticoagulation, come back again, chest them again. If their clot is broken down, then we cardiovert them again at that point. So we do, we make sure that these people are very stable before we do this. Sedation and amnesia are very brief. General anesthesia with standard anesthetic monitoring. Avoid lidocaine. Antiarrhythmic drugs should be available. Advanced airway equipment. Ventricular ectopy or bradycardia related to sinus road dysfunction can occur post-cardioversion. And this is, let me show you something that comes out. And this is where I'm going to stop for today, and we'll start back on to the next week. I want to show you everything this is a lawyer's dream. I hope it comes up. Yeah, it's coming up. The reason this is a lawyer's dream is because this is why YouTube is very dangerous. Okay, because it shows bad things being done. What do you see first? They're pre-oxygenated with an ambu bag. Wrong. Okay, so that's the first bad thing. Okay. Okay. Now the next thing that happens too is, okay, the good thing is nothing bad happened to this guy. Is that he's now clearing. Okay, as you can see that he was sedated appropriately. You can see he's making noise. Okay, so and that's good. He's not going to have any recall, believe it or not. Okay, so that's how you want them. You want them lighter, okay, than heavy. If the person has to be ambu bagged, okay, what's really funny is now he goes to FiO2 of 100%, which I don't understand why he did that. Okay, doesn't make any sense. Okay. All right. Now, when you do a cardioversion, it is joules of energy. Okay. If you're touching the patient or you're touching the bed, you may get shocked. Okay, and trust me, it's not fun to get shocked. Okay, it will actually hurt you. Okay, and that's it. They're done with the case. Okay, you can see they're giving a little Diprivan. Okay, and that's all it takes. And they've got a pulse oximetry. Everything's being monitored properly. Okay, and they're going to shock him one more time, I think. Yep. And that's what you see. You see that reaction from the patient, and you think that the person is going to have recall. The way you know that the person is not going to have recall is you ask them to look at you, and you'll see that the person will have nystagmus. Okay? And when you see that, that person won't have any recall at all. Okay?
So I'm not sure who's responsible for looking after that.
Okay. Now they're back to sinus rhythm. You can hear it. Okay? So, but make sure that you don't pre-oxygenate like that. It's not appropriate. Okay? Make sure you give your FiO2 mask, and that's the right thing to do. Okay?